Okay, good morning everybody and a warm welcome to our session Integrative Medicine in Global Health, Pathways for Implementation. You will hear about identifying key approaches, collaborative models and practical solutions for integrating traditional and complementary medicine across diverse global health systems. Traditional complementary and integrative medicine, or T&CM, encompasses medical systems and practices that are distinct from biomedicine and that are often not fully part of mainstream medical health care. These medical approaches have the potential to improve global health care, as they often have emerging evidence of effectiveness and safety. They are cost-effective and can provide access to health care with comparatively few resources. Traditional medicine is the only access to healthcare in some regions of the world. However, the World Health Organization, WHO, calls for the targeted and structured combination of evidence-based T&CM with biomedicine globally, envisioning universal access to safe, effective, and people-centered T&CM for the health and well-being of all. So by emphasizing prevention, resilience, and a health-promoting lifestyle, T&CM is an important approach to improving health outcomes in various fields of healthcare. And it also fulfills the demand from patients worldwide. Between 1/4 and 3/4 in most countries of the world use complementary medicine and use T&CM, and a substantial proportion of the world's population supports the integration of T&CM into standard healthcare. However, the reality, as always, is a bit different. Only 11 of the 194 WHO member states fully integrated T&CM into their healthcare system so far. So we're beginning to walk this road, but we're not there yet. So we dedicated this session to implementation of traditional complementary and integrative medicine. This session will discuss opportunities and challenges of implementing T&CM on a global scale. Our top-tier international panel of speakers will describe strategies for integrating evidence-based T&CM into biomedical healthcare globally, overcoming regulatory challenges and promoting collaboration between different health systems. And in the session she chaired yesterday, Dr. Hiba Buchner pointed out that it was just the first session ever held on T&CM on the World Health Summit. And now, less than 24 hours later, the second one is already taking place. So what exciting times we live in for T&CM today. And pioneering this increased awareness is undoubtedly the WHO Traditional Medicine Strategy 2025 to 2034, which our speakers will also address in their presentations. And this certainly is particularly true for our first speaker, Dr. Shyama Kuruvilla. Dr. Kuruvilla is the Director AI of the WHO Global Traditional Medicine Center, where she leads work across research and innovation, health systems integration and quality, cross-sectoral partnerships, and the convening of a biennial WHO Global Summit. The center's work includes a focus on leveraging responsible artificial intelligence to connect centuries-old healing systems with cutting-edge technologies, scaling up evidence synthesis and innovative solutions for the health and well-being of people and the planet. Dr. Kuruvilla holds a PhD from the London School of Hygiene and Tropical Medicine, a Master of Science from Cornell University, and an undergraduate degree from Christian Medical College, Vellore. And today, Dr. Kuruvilla will speak on restoring balance for people and planet, integrative pathways to future-ready health systems. So please join me in welcoming Dr. Shyama Kuruvilla to the stage.
Do I need to do anything to get... wonderful. Okay. Thank you all for attending. And I see many of you were there in Chapter 1 yesterday and Chapter 2 today. And thank you for this growing interest and collaboration. So, restoring balance for people and planet. This is going to be the theme of our second WHO Traditional Medicine Global Summit. And it seems like this is at the heart of all traditional medicine systems and something that the world really needs now. And what WHO is doing is bringing the science and practice of restoring balance. And thank you, Holger, for this opportunity and all the colleagues here in terms of moving the WHO global strategy that you may know all countries, all member states adopted at the World Health Assembly just this year in May. And so now quickly moving on to how we can implement this strategy is a priority. I'm not expecting you to read this, and I will just give you a synopsis, a one-page overview of the global strategy. So the vision is a world where there's universal access to safe, effective, people-centered, traditional, complementary, integrative medicine for health and well-being. And the goal is to do this in an evidence-based way. There are guiding principles of being holistic, sustainable, equitable, respecting indigenous people's rights, and that it's people-centered. And of course, over there, you'll see integrated health services as a principle. And there are 4 strategic objectives, and I won't read through the details, but they broadly strengthen around evidence, around regulation to ensure safety foremost, and efficacy. Integration, again, based on safe and effective T&CM, and optimizing cross-sectoral value. And this can only be done with the engagement of communities. So, 4 words to remember: evidence, regulation, integration, collaboration. Okay. And that's what we're looking to implement. My colleagues, as you can imagine, there's a team looking specifically on best practices and the evidence on integration, and advised me to start with some clear definitions. So integrative medicine is sort of a vision for the future. And the global strategy talks about an interdisciplinary, evidence-based approach to health and well-being, using a combination of biomedical and traditional and/or complementary medical knowledge, skills, and practices. But what we are talking about now is integration, which is the organization, management, financing of the health system that would allow delivery of accessible, culturally appropriate, people-centered T&CM and biomedicine. So it's a combination of services that are provided in an integrated way versus integrative medicine, which is a new, perhaps, field or approach that we would work towards. I'm not sure how many of you know and love the WHO Health Systems Framework, which has the 6 building blocks on governance and financing and workforce and medical products, etc. Then we had the UHC umbrella, the universal health coverage that's supposed to protect everyone by making sure there's financial protection and access to the highest quality health services across the continuum of care. We have the PHC approach, which is really grounded in social justice, and it's about primary care and multidisciplinary approaches and community engagement. We now have T&CM services which have to fit in. And there are many, many variations across countries and to the degree to which this is happening. But what is important is to understand what is the role of governments. And this will vary based on the type of government, the type of context, but really what is it that governments need to promote, to mitigate the risk for, and to ensure quality and equity that individuals themselves might not be able to do, or that there are market failures in that the private sector alone cannot do. And that each, however, stakeholder has a role to play. I don't know over here in this room how many of you practice some form of T&CM, whether it's meditation or mindfulness or yoga or a herbal tea. Yeah. And I think this reflects the situation the world over, where billions of people access TCIM, either because it's their primary access to healthcare or a preferred choice. And even here in Germany, we understand a recent population-based survey shows that 70% of the population here are using some form of TCIM. So with this in mind, WHO has been looking more at a conceptual framework of how integration, so again, not integrative medicine, which could be a discipline in and of itself, but integration in systems could happen. And there are these two axes. One is from decentralized, which is people-led, practitioner-led, demand-driven, community-engaged and owned models that are quite diverse, to centralized, government-coordinated systems. And then you have pluralism to unification, to saying that multiple systems, ways of thinking, ways of perspectives on the world are possible, to a more unified, here's how we combine, and here's, for example, traditional Chinese medicine in China. It probably has a more unified integration approach. And so the four kind of quadrants then map out into people-led, community-led, personal choice-focused integration. Then practitioner-led, where there is some form of association, professional coordination. You have category B, which is centralized, but allowing for multiple traditional medicine systems to be practiced. For example, in India, there is Ayurveda, yoga, Unani, Siddha, the whole range of services. And then that are centrally coordinated as well. And then centralized unification. So this is not a prescription, it's a conceptual framework on how the different types of integration might occur. Having told you about the 6 building blocks, I'd like to just put up on the screen how systems have been envisioned in traditional medicine. And you'll see that there are more than 6 building blocks. So, for example, this is on systems thinking in Ayurveda, where it's about each person's relationship with our societies, with our planet, with the universe. So it's almost a cosmological system here. And how imbalance in any one part of that system affects everything. And so that interlinked nature of people's and planet's health and beyond and across generations is something that we need to wrap our minds around. And you will see this again in the Neijing, which is, the basis, the foundation for traditional Chinese medicine. Again, you'll see this wonderful universal systems perspective that we've sort of lost now. Health is not individual. It's not an individual state. I think what traditional medicine systems teach us is that it's deeply interconnected between the health of yourself, your society, your planet. And this balance is not a single state to be achieved. Every day we're seeking balance, achieving that dynamic balance and across time as well. And so I must now actually quote something quite inspiring and reorienting from Professor Matsubisha when one of the first conversations we had, where he was saying, and these are just 2 examples, right, from indigenous peoples' knowledge for millennia as the first stewards of biodiversity and health. This interconnectedness, this inextricable link with the lands, with the waters. It's as Nicole Redworth very powerfully said yesterday, is intrinsic to this. And Professor Matsubisha was talking from African traditional medicine, saying, yes, we've been here for millennia, and we have this vast scope. So when we talk about integration, we are happy to make a small space for you, biomedical health systems, to orient to the way that traditional medicine has been thinking about things. So in addition to the two definitions I gave earlier about integrative medicine developing into a discipline, integration about bringing services into current health systems, I would like to add that third dimension about what can future health systems learn from traditional medicine and this interconnected way of living and balance that we would all aim for and would benefit all people and the planet we share. So trying to capture some of this in our WHO Traditional Medicine Center theory of change, as it were. Right in the center, in the green circle, we have the 4 global strategy objectives on evidence, regulation, integration, collaboration. And when I talk about evidence, please know it's not about, again, trying to fit everything on traditional medicine into, say, a randomized controlled trial, but it's about evolving science so you can understand the effects of, say, meditation, which you can now through fMRIs and EEGs and see the changes in your brainwave, just as one example, right? Or genomics, artificial intelligence. I think it's so exciting to see the new technologies providing this bridge between the ancient wisdom, and modern science. We have regulation that's, again, with such cultural ecosystem-specific systems that we need to have global standards and categories that enable that exchange. And then the integration that we were talking about and collaboration. And you'll see sort of WHO's work, but ultimately the role of everyone in this room and everyone having a role to play in how you center yourselves to have health and well-being with your communities, families, and the world overall. And contributing, as you can see, how we talk about balance now, whether it's the laws, whether it's the engagement of quality, but flourishing, not just in an abstract, new agey way, but really with the hard economics as well. The wellness industry is one of the fastest growing economic sectors right now, projected to almost $9 trillion globally, right, by 2028. So let's do this in an equitable, sustainable way that restores balance. So the next steps, we are talking about integration and look forward to all our colleagues' inputs on this with very concrete examples of how this is being done in different contexts. From a future health systems perspective, saying let's move towards integrative medicine, bringing these perspectives and the science together so that there are concrete solutions for health and well-being of people and planet. And this is the theme for the Global Summit, and we hope to highlight the science, the practice, and the holistic nature of this joint human quest. So with that, I thank you all for listening and look forward to the engagement. Thank you.
Thank you so much, Dr. Kuruvilla, for this inspiring presentation. And I'm certain that there will be loads of questions to Dr. Kuruvilla, but I ask your patience. We will have a joint Q&A after every speaker made their presentation. And so please remember your questions and then pose it at the end of the session. Our next speaker is Professor Gilbert Modlalepula Matsabisa. Professor Matsabisa is a professor of pharmacology and director of the Indigenous Knowledge System Health Lead Program at the University of the Free State, South Africa. He is also co-chair of the WHO's Second Global Traditional Medicine Summit and a member of the WHO Strategic and Technical Advisory Group on Traditional, Complementary and Integrative Medicine. He holds a PhD in pharmacology, and his areas of specializations include the pharmacology of traditional medicine, drug discovery and development, the formulation research of traditional medicinal products, to proprietary finished final products. His research encompasses all value chain of new drug research, basic science research, discovery, development, pharmaceutical research to clinical trials. Professor Matsabisa's work contributes to current government policies and initiatives. And Professor Matsabisa will today present on restoring balance for people and planet Integrative Pathways to Future-Ready Health Systems. I welcome Professor Matsabiza to the stage.
Yeah, thank you so much, Holger. Thank you so much, Holger, and thanks to the colleagues and everybody. What I want to do today is maybe give some examples in terms of how Africa could contribute to the strategy that I think, Dr. Sharma mentioned. But also before I do that, talk about, the challenges, because if you do not know what the problems are, you may not be able to move forward. So that's, I think, what I want to do. But yesterday, I think in the lecture, we were more talking about, workforce development. And I was then asked to say, what is a workforce development? So I had these pictures for, I think, Hiba, to indicate these are some of the staff members. And the special thing about these staff members are actually traditional healers themselves. They are practicing traditional healers, and for us, these are an interface between traditional medicine and the science. The lady on the top, I think, left, that's a lady that we employed to start up a medicinal garden. She had a high school, I think, certificate, but then she said, I want to study. And we trained her, got her into university until she actually got her PhD. And then the young man in the middle is my student, Paul. He's also a traditional healer, and he's doing now his master's in pharmacology. And then the young lady also is my staff, looking at all the international relations, but she's a traditional healer. And then the two ladies, which is Paul and Tobeka. Tobeka is also a traditional healer, but she had an interest in legal matters. And we then took her and said, fine, we'll train you and help us, I think, with all the legal, aspects. So in fact, I brought them to the first global summit, in India, where they contributed, I think, during that. So that's, I think, it's very important, because as you listen to what I say about African traditional medicines, you'll begin to realize the challenges. I'm not marketing myself, but these are, I think, our facilities. This is a national facility within the School of Clinical Medicine, but we specifically do research in clinical pharmacology and basic pharmacology, and more onto the drug discovery, working with communities, and trying to find, I think, health solutions based on a holistic, approach. That's the end of that. But then what do I want to talk to you about? One, let's look at African traditional medicines. What is African traditional medicines? What are the challenges, the research, and then what is needed for it to get institutionalized? So that's what I will sum up to be. If you look at African traditional medicines, unlike, other systems of health, people do not go to school, to universities to become traditional healers. There's nothing like that. They get to be appointed, anointed in a manner that I also do not know, and they get chosen, and then they have these mentors that train them to become traditional healers outside of any formal university setup. And they do not do any documentation. Everything that they do is actually transferred through a knowledge, oral. This is what you do. You go and collect that plant. This is how you mix it. And they grow up within that system, and which makes it very difficult for us to say, what is it that they do? And that's a mystery, and that's a challenge that we, as I think Western trained people, seem to have these questions, because we do not know the philosophies. We do not know sort of the principles of African traditional medicines. Why do they do what they do? And we are easy then to immediately say, this is mystery, this is something that's hidden up, I think, in secrecy, and therefore there is no system in it because we do not understand it. And that's what we need to do, I think, in our center, to begin to understand what are the actual philosophies and the principles of African traditional medicines. And that's why we have those traditional healers. But also, if you look at in terms of institutionalization, there are many, challenges, but I would want also to put the blame squarely onto the traditional healers themselves, to say they need to begin to open up, have trust, but one may understand that they might have been, I think, sort of abused for a long time, so the challenges of them opening up are real. But we say they then need to open up so that then we can understand what they do. Policies in Africa on traditional medicines are fragmented. Each country may do whatever they do, but there is no sort of a coordinated system where we could come up and say, let us have a policy that could be applied across all, I think, the 50-something African, I think, countries. And that's the problem. And you have these policies that are not funded. So you put up a policy, it's not even translated to the actual people that really need to understand that policy. It gets put up into an office, understood by the officials, but the actual people do not understand that policy. That's where the problem is, because you make the policy for the people. Funding for the evidence, it's a big challenge. Some of us in South Africa may be lucky that I think, we do get funding, to do the research that we do. But it's very difficult if one looks at Africa and say, how do you fund a clinical trial on traditional medicines? Many countries would not do that. Many countries in Africa do not have the R&D or the facilities to actually manufacture or do research and development of traditional medicines. And these are the real challenges. Now, traditional medicines is endowed in secrecy. And at one stage, we understood that, okay, the secrecy, it is a form of them protecting their intellectual property, which was good. But then if we open up and saying, let's work together, let's become inclusive, what incentives do we give traditional healers as researchers, as health workers to come and work with us? Because they have been in this situation where knowledge was expropriated without compensation, and then they have become very reluctant to come forward. So we need to come up with some incentives and say, let's incentivize them to come forward and work with us. And that's what I think some of the things that we want to overcome. So generally then in Africa, what would be needed for us to talk about institutionalization of traditional medicines? Many countries in Africa tolerate traditional medicines. We tolerate it. We say nothing about it, but it's actually not institutionalized. You will not find it in your formal health systems. We talk about it and we do nothing about it. That's, I think, where the challenge is. And now, what makes it difficult is, as I said, we need to start creating policies that can be implementable. Policies that we can enforce and create laws based on those policies. A lot of some of these policies are really drafted by people that we are not so sure whether these are legal drafters of policies or these are just officials that were drafting that. So we need to change that. But the other problem is many universities, many people in Africa do research in traditional medicines. It's uncoordinated, it's not directed research, it's not applied research. And therefore, it becomes very difficult even for governments to invest in such a research because you don't see any tangible outputs of that research except some publications here and there. But we are actually at an era where we are saying research needs to give impact. That's the most important thing. Yes, it's good to publish, but we must have a societal impact if you are using government funds to run your research. And therefore, we need to begin to change how we fund the research and how we do research in traditional medicines. Because if we continue publications, the communities, the traditional healers are saying, Professor Matsabisa, it is good for you because you'll get promotion and you'll become a professor and I remain where I am. So what is the point of me working with you? And that's really fair. To say, I develop, but I will remain where you are. So I use you as a, stepping stone to get up there and say, thank you so much. And you still are there for the next decades. So we need to change how we do research, and hence why I think the strategy talks about inclusivity. The strategy talks about meaningful participation, of communities. And that's really what we need to do. I said to Sharma one day, I think in the next summit, we want to see that summit as an action-oriented summit. We don't just want to talk. There must be action. But also, what we want to begin to talk about is the dichotomy. You go to Africa, and you find that in Africa, a lot of the people would say, we don't understand what traditional medicine is. And I argue and say, if you are an African and you have grown up and you were born in Africa, one way or the other, you have been exposed to traditional medicine, and therefore you cannot come and say to me, you do not know what traditional medicine is. It's just an indoctrination that has been put into the minds to say, do away, I think, with this. Yesterday I talked about the Witchcraft Suppression Act. In South Africa, we had the Health Professions Act that also barred medical doctors to work with traditional medicine. We had the Pharmacy Act that barred pharmacists to work, on traditional medicines. And we have tried to do away with those and begin to say we need, therefore, to develop probably a curriculum at foundation level, a curriculum at our medical schools that begin to teach integrative pharmacology, integrative medicine. And I think South Africa has taken that, and we are moving to begin to say this is needed. If you are a clinician, you leave university, the first encounter in Africa that you'll have, definitely you'll have a traditional medicine-related health problem. So you cannot avoid it. But also we talk about this formalization, of the sciences curriculum. Also in the sciences itself, how do we teach? I say to my students, I do not like phytochemistry, but I like pharmacology and traditional medicine. So don't come and talk to me about beautiful molecules and beautiful molecules that have no meaning. To me, if it's a beautiful molecule, it must have a pharmacological action. It must be applied. That's why I don't like phytochemistry. So, but we also are beginning to say we need to have a training of our traditional healers themselves. How do we prepare them, to train in an integrated health system? Remember, they work in their own little houses there, they do whatever they do. In most times, they are not regulated. But if we integrate them, we need to start beginning to say, let's begin to formalize their training. Let's begin to have some trainings, that prepares them to work in a formal settings. But similarly, I think in Africa, I think in Germany, I think you are fortunate. You have some people that understand. In Africa, we also need to begin to train our health professionals to begin to accept and understand traditional medicine system. I worked at Groote Schuur Hospital, for many, many years before I went to the University of the Free State. And Groote Schuur Hospital, that's where the first heart transplant was done. And we knew that in the wards, my wife works in the ICU, people would still bring in little bottles of traditional medicines in the hospitals. They do. And you cannot stop that. And the best thing that we have been saying now was, the doctors, I think, allow the patients to open up, to be free to you, so that the patient can tell you that, doctor, I'm not just using your medicine, but I'm also using something else, so that we can better manage the patient holistically and collectively. And that's what we want now to begin to train our medical doctors. Research and how to influence policy. One, we talked about participatory research from grassroots, community research, let them participate. What we have set up is we have these research MOUs, set up a small committee. When we do research, we sit with communities, we discuss the project. Why do we do that? We do that so that we can create trust. If we have challenges, they know what our challenges are. And then if we have successes, we share those successes. And that's what we need to do in terms of research. But then I think the research needs to provide policy guidance. Policy guidance, whether it is in terms of, I think, access, to information, access, I think, to knowledge, genetic resources, benefit sharing. That's what I think research needs to do. You need to have research to inform a good policy in any country. So what would then be the requirements? One, I think we cannot institutionalize traditional medicine in Africa if it is still fragmented. And again, if we have not sat down with them and begin to have, I think, a pathway to say this is where we need to go. And that's what we need to be looking at. And also, I think we need to have this training, of continuous education training for our traditional healers. It is important because even traditional medicines, natural medicines. Yesterday, I think one of the students asked me, how comfortable are you, Professor, with the word traditional medicine? I mean, I said, okay, we can use many words for now. We use traditional medicines, but we may look at natural medicines and things like that, because the implication that you have when you say traditional, you think it's static, it's things of the past, while it's actually things that happen now, and traditional medicines keeps evolving and changing with times as well. There are too many diverse policies, and one of the recommendations probably that I thought of was probably we need to have these WHO regional centers that should work with WHO and have a coordinated, approach, so that there is uniformity, there is standardization. You normally argue and say when you are in South Africa, you see a lot of posters, a traditional doctor from East Africa. And the question asked, how do we know that this person is a traditional doctor? From where they come from? You don't know. So if we could then have, I think, some of these harmonization in terms of how we do traditional medicines. And I'm not saying we put all the practices, I think, to become one, because in Africa, traditional medicine practices are different. It's unlike maybe in India where you have, a system that's there. If you go to West Africa, when they practice traditional medicines, it's slightly different from what they do in Southern Africa. And we need to then see how then do we harmonize that. But also we look at the WHO regional centers. I think this is the thought to say we have the WHO Global Center. If we could have regional centers that would then work with WHO Global Center, so that we have an agenda to drive traditional medicine forward. And we can then collect, I think, the evidence that we want and agree on what is the evidence that we need to collect. And that would actually help us move faster, together. Remember, WHO normally gives guidelines, and the countries end up in saying, but it is just a guideline, so therefore it is not binding. So we need to find a mechanism to say, if we are serious about traditional medicines, how then do we move forward? I hate to use the word because I said the same thing to you, Chairman India said, maybe we should find a binding thing to member states to move things forward and not say just it's a guideline and therefore I may decide not to do that. But also I think we are talking about, mobilize policymakers, mobilize our ministers of health to begin to accept, that there is a strategy and they need to do, I think, what it is needed. We need to have this political, I think, infrastructure. If we are into institutionalized traditional medicines, there should be some infrastructure in place. A lot of the traditional healers, when you talk about institutionalization, immediately they think that they will be accepted into the main hospitals and work, alongside doctors in the main hospitals. And we keep saying, but no, you can't, because the two systems are different. You need them to collaborate and work together. I mean, they burn incense, and you have smoke detectors, and you'd have trouble, I think, if you do that. They beat drums. Some people need peace. So you need to begin to say to them, how then do we work together harmoniously, as equal partners? But don't expect that probably you'll be in the same, I think, room. In conclusion, I think, Chair, we are saying, yes, we need to have policies, towards institutionalization. These policies must be, I think, inclusive. These policies must be well drafted and communicated well to the people that really need them. The second thing, I think, the research, innovation, development, and its industrialization should also be, I think, a research that is inclusive, that is participatory, and therefore we should begin to think about how do we incentivize our communities to come and work with us so that they do not see researchers and scientists sort of empowering themselves. But also, how then do we generate that evidence? How do we teach communities, to document, to begin to generate, I think, the evidence themselves? But then I think we talk about the application of services, and this is what I was talking about, that we see, I think, systems. It may not be, I think, what's happening in Germany, what's happening, I think, in China, but probably Africa could come up with, I think, its own unique system to say, how then do we work together with traditional healers, I think, in a mutually respectable and acceptable, manner. I can emphasize, I think it is research centers. I think, WHO has got a lot of WHO collaborating centers. How do we mobilize them? How do we bring them together and give them directed research, a focus, to say, this is what I think, we are looking for as a WHO collaborating center. More importantly, at least our traditional health practitioners, our traditional healers have gone to school now, they've educated. We begin to teach them how to document. We normally say, in Africa, when the library burns, you lose everything. So when that traditional healer dies, you lose everything, because everything is in here. But I think those documentation, if we can formalize them and standardize them so that then they can fit, the requirements of the regional and the WHO Global Center for documentation, I think that would be important, so that then we have all those. I think with all that, I just wanted to say, I think, to re-emphasize what Shaima was saying about those objectives, strengthen the evidence base, we do proper research, support safety efficacy. That's what we need. And then the integrative, systems into healthcare system. That is important if we are to move for a holistic, patient, care, but also to look at community empowerment. Thank you so much, Chair.
Thank you so much, Professor Matsabisa, for this fantastic presentation. Our next speaker, and remember to write down or remember your questions for the Q&A. Our next speaker is Professor Amy Steele. Amy Steele is co-director of the Australian Research Consortium in Complementary and Integrative Medicine, or ARCIM, at the University of Technology, Sydney. As an expert in women's health and complementary medicine, she is ranked as the #1 traditional and complementary medicine researcher in Australia since 2021. Dr. Steele received her PhD in public health from UTS and accepted a competitively appointed industry fellowship at ARCIM. With an enduring focus on furthering the knowledge base in her chosen fields, Dr. Steele has authored over 250 publications on complementary medicine and health promotion. Her research has informed health policy reviews and developments in Australia and also internationally. Her work has informed WHO policy documents and national policies and reports in Bangladesh, here in Germany, UK, and Australia. And Dr. Steele will enrich our session with her presentation on professionalization as a pathway to integration, strengthening education, regulation, and representation in TCIM. I am delighted to hand over to you, Amy.
Thank you very much, Holger, and for our other speakers. It's been an excellent warm-up to the session that I'll be talking to, and some of the points that I will be expanding on have been touched on in Dr. Kuravila's and Professor Monopitsu's presentation. So I'm focusing in on traditional medicine professions because, and particularly the professionalisation of traditional medicine healers, practitioners. It's a critical element for integration and something that certainly it has everyone has a role and a contribution to make in ensuring that the traditional medicine healers, practitioners are in a position to be integrated in a meaningful way into the health system. So, as has already been mentioned, so I won't spend a lot of time on it, there's only a minority of WHO member states that have fully integrated TCIM into their health systems. And there's lots of reasons for that, and there's particular barriers around it. Certainly there's policy challenges and regulatory gaps. There's issues around the legitimacy of the workforce that have been raised by people outside. Certainly inconsistent education standards and limited interprofessional collaboration. So there's other reasons around that are particularly important that will also need to be addressed. And one is that in a lot of instances, they're actively excluded from health systems, and sometimes passively excluded, but often actively excluded. There's also limited research opportunities, and that affects public trust and puts the professions in a position where they're vulnerable to co-option. So the point that was made before about intellectual property and them being nervous about sharing their own knowledge is one area. But also their concerns that not only are those benefits going to be resulted through commercialisation, but to see them adopted by other health professionals, and that for the TCIM practitioners to continue to be actively excluded is another fear that they hold. So what is professionalisation? It's a transformative process for any occupation where it evolves into a recognised profession. And there's lots of elements. There's a lot of thinkers have done work on professionalisation theory. I'm not going to burden you with that extra information today to too much detail, but happy to talk about it. It really comes down to formal structures, rigorous standards, and holding legitimacy within society. And ultimately, that's what professionalisation, where it transitions from being a job to a profession. And one of the things that we need to support is for TCIM healers to have that structure, the standards and the legitimacy in order for them to be able to be fully integrated into healthcare systems. So that means recognising and identifying the specialised knowledge that the profession holds. It also identifies a code of conduct and principles that govern practice, the importance of them actually having a voice and coming together and being able to communicate their particular needs as a profession to people from the outside of the profession. In having that level of professionalisation, that certain level of boundaries that they develop through the professionalisation process, it also gives a clear identity, which allows for the public and other people from outside of the profession to recognise them and to be able to engage with them as a cohesive group. Even if there's some heterogeneity within the group, it's them being able to clearly identify them as a group. And then in doing so, giving them some scope to be able to define their scope of practice and practice within that scope of practice. So these things are things that we take for granted for most health professions. Everyone knows broadly what a nurse is, what they learn, how they practice, what their position is within the health system. Equally, medical doctors, dentists, physiotherapists. There's clear boundaries and understanding around that. And what we don't have for a lot of TCIM professions is that clarity. people don't understand what they do, they don't understand how they can contribute, and they don't understand enough. And in a lot of instances, even within the professions, there's not enough of a conversation around these issues that's been had that's allowed them to come to some understanding so they can communicate that. I do a lot of research within osteopathy. I'm a naturopath myself, and I'll be using naturopathy as a case study today. But just simply being for osteopaths to be able to communicate how they're different to chiropractors and physiotherapists, and what their unique selling point is to their health system is actually quite a challenge for them, and something that they're still grappling with globally and within countries. So there are 3 pillars of professionalisation I'd like to propose to you today. And as I said, some of these have been already raised from our other speakers and brought up in the session yesterday, and I'm going to really focus in on them. So the first is education. And that's really looking at accredited training, those structured curriculum that's not necessarily consistent. You don't get exactly the same training in a medical school if you go from one university to the next, but broadly the same content is covered, and there's an agreement about what that foundational content is. And that means that no matter which university an individual goes to train to become a doctor or a nurse, everyone in that country is confident that that person has received a consistent level of training. Regulation as well. So having standards and oversight that protect the public, and the importance of those standards being something that's enforceable, to make sure that protection is something that can be consistently applied. And representation. And this is often one that's probably the most overlooked, is the importance of the professions themselves having a voice, that a unified body of some kind, again, that doesn't always, because I always say if you get 5 naturopaths in the room, you'll get 10 opinions, but it doesn't mean that they all have to agree on every point, but there is a body that governments and other agencies can go to engage directly with the profession in a formal way. So those 3 pillars are actually really critical if we're going to see an advancement of integration of TCIM professions. And the other thing to realise is they're interdependent. And so it's really not okay to pick one and let the other 2 fall aside. All 3 have to be acted on. Now, you may choose to act on one first, but the consciousness of the other 2 is also really critical in order to see this progress. So let's have a little bit of a closer look at what the education pillar looks like. I mean, obviously education is the foundation for professional practice. And there's lots of different ways that can look. And this is not necessarily to say it has to be integrated into a formal institution if that's not the particular way that the health system, the healing system has always practiced and trained. But there needs to be some level of accreditation and a level of standards of a curriculum to make sure that the safety, competence and evidence-based practice is a foundation of how these TCIM practitioners are engaging so that they can be better integrated into the health system. So having good quality education does actually help with legitimacy and public protection. So that has 2 dual benefits. So that involves curriculum standards, developing comprehensive evidence-based curricula that integrate traditional knowledge with the biomedical sciences and research literacy. And these are points that have already been raised today, that we need to find a way in order to have the traditional healers have knowledge around these biomedical sciences and research literacy, as much as we need to train physiotherapists, medical doctors and nurses around the different roles that TCIM practitioners may have, and giving them some familiarisation to TCIM. Having accreditation systems is really important as well. Independent external review that ensures programs meet established quality standards and prepare graduates for safe and effective practice. That independence is really important as well, and it becomes quite challenging in when we have professional bodies, and I'll give you an example in a moment about where this can be challenging, where you've got a limited number of leaders within a profession. Some of those leaders are perhaps within schools in which training is occurring. They're also sitting on professional organisational boards or bodies that are responsible for overseeing that. And there are definitely examples that we have globally for naturopathy where that's actually been highly problematic, where the organisations responsible for accrediting the programs have representation from people whose programs are being accredited. So having that independence in external review is really important. But equally, you need people who've got topic knowledge and who are doing the external review. To make sure that there is not just a curriculum pedagogical review, but actual content that ensures that the clinicians who are graduating for the program are appropriately qualified. Also, development for the faculty is really important, making sure there's training and support for educators to build their clinical competence, and engage in scholarship and effectively integrate evidence into teaching. One of the things that I often see in traditional medicine training programs is the clinicians who are supervising clinical practicums, which are usually as part of the penultimate part of training. They're usually at the end of the training after people have had all their foundational knowledge. They're usually the least scholastically qualified, because they're drawing on people who've got clinical experience. So you often have people who have a lot of undergraduate training. When they build these courses into universities, the people who are supervising their final piece of study are usually not qualified in that way, particularly when there's a transition that's happening within a program. And that's important for these faculty. It's important to have people with clinical expertise supervising the practicums, but they also need to understand the evidence base, the research literacy, and those kinds of things. So from that point of view, also having clinical training that gives diverse settings experience. There was a really great comment on that point before, but a lot of the times clinicians are being trained for one-on-one clinical care in private practice, and that's what they're being developed to deliver. We need to have experiences for clinicians that prepare them for the diverse settings that we would like them to be in, so that when they are integrated into the health system. So being proactive about those things, being forward-thinking, and having an opportunity to think more broadly about where are the opportunities for these T&CM practitioners to situate within the health system, and giving them skills and supported learning opportunities to feel more confident going into those systems when they graduate. A couple of examples of education frameworks in practice. So Australia and New Zealand is a really great example of internal conflict. So we don't have a mandatory independent accreditation body in Australia. And as a result, we have national standards that education providers are refusing to comply with. So even though the profession has developed accredited curriculum standards, the educators are not meeting those standards. And they're choosing which ones they want to and which ones they don't want to. We have a government agency that provides pedagogical oversight and ensures that all of the other requirements of the course is there, but the actual education standards are not being met. Equally, New Zealand are trying to adopt the Australian standards because they don't have enough professional formation in order to develop them themselves. And they, however, are having a lot of issues and pushback from, whilst some institutions are keen to do that, others are providing a lower level of training. And so when you have this lack of consistency in the education, it makes it very difficult for the profession to really advance. It becomes confusing if the profession is engaging with the government, trying to explain who or what the little minimum level of training is. As a different example, in Brazil, there are programs there that have explicitly been developed to ensure that the graduates are meeting some of the policies and public health aims that are in place for T&CM in the country, and particularly preparing graduates to work within the universal health system. So there's very different kind of examples of how much impact education frameworks can make to the ability for a health profession to progress and to integrate more effectively into the health system. So let's talk about regulation. This is obviously offers legal recognition and public protection. So regulation can appear in lots of different ways. It provides a framework for safe, accountable practice and supports integration into the health system. There's lots of different models for regulation that are out there, but ultimately statutory regulation or occupational licensing are the two most formalised models. There's usually built-in defined scope of practice or competencies. There's entry to practice requirements, mandates for a certain amount of continuing professional education and certain types often of continuing education, mechanisms in place for complaints and disciplinary actions, and quality assurance frameworks. These are all the things that regulation can offer. Now, regulation as I said, there's different types, and just to provide a spectrum, statutory registration, as I said, is the most formalised. So in the USA and Canada, statutory registration, when it is in place, gives the clinicians access to a broader range of potentially restricted acts. They also have more formal integration into their health system. They've signified a higher authority, they've got a recognised scope of practice, and they really can situate more comfortably in the health system. This differs to co-regulation, in which we can end up with a formal arrangement between a professional body and a profession's formation and the government in some way. So an example that we have of co-regulation in Australia is the Dietetics Association, which isn't regulated, does not have statutory registration, but in order to work in hospitals or to work with Queensland Health, you have to be a member of their professional association, which requires that you meet certain requirements. So that would be an example of co-regulation. And voluntary regulation is where the profession self-regulates. They set their own standards, they attempt to enforce them. And in some ways, where we have issues is where you have multiple standards from multiple associations and no government support when the people who are supposed to be complying with those standards are not doing so. And so I think that would be an example of what's happening in Australia and New Zealand with the education standards. Keeping in mind, though, statutory registration is not always a good thing. In South Africa, there's what would be considered to be exclusionary regulation, in which regulated naturopaths face legal exclusion if they are prohibited from forming practice partnerships with people who are registered professions. So there's legal exclusions that are in place. We also have like a civil law approach in Europe, in which regulations that are in place are not applied to the health professions directly, but they exclude them from doing a whole range of things that are considered to be the sole remit of biomedicine, including prescribing. And this then means that there's a lot of the training that happens in those countries, the trainers choose to omit biomedical subjects because they don't see the point in training their health professionals in some higher levels of biomedicine. We also can have issues around workforce stratification. So if you've got two different levels, in Puerto Rico, they've got naturopathic doctors, which are considered the more advanced trained, and licensed naturopaths, which have got a lower level of training. The problem is that for governments, that can be really confusing, and for agencies that the professions are trying to deal with, they're not really sure who's doing what, and those boundaries around which profession or which stratification is allowed to engage can be really difficult. And probably one of the biggest issues that we have is even within Europe, the inconsistent regulation between countries affects the education standards within those countries, and that therefore affects cross-border mobility and people's ability to actually move and practice in different countries. The third pillar is representation, and this is, as I said, often undervalued. And sometimes the professions need additional support to set these things up. But certainly this allows the health professions, the T&CM professions, to have voice in policy and health system dialogue. Governments need to have a formal organisation that they can reach out to. Otherwise, they're just calling up the person that works in their suburb and asking for input on something. They need to have that formal coming together. And sometimes the profession itself needs some support in setting up the structure around that and the guidance, whatever the terms of reference might be, those kinds of things. But these are really important groups to set up to support advocacy into policy if they need to engage and have representation in focus groups and those kinds of things. They can also have really active input then when the government is setting professional standards, codes of ethics, if regulation is being in place. If you don't have a voice from the profession, then this is where you end up with people who don't really know what they're talking about setting the regulatory standards for a profession. And also those professional bodies can also support interprofessional collaboration at an organisational level. So unfortunately, naturopathy is the case that I'm using, operates often in a closed ecosystem. So engagement is not very strong in a lot of situations. They're not really moving beyond the profession that they're in. There's issues around the training gap with multidisciplinary training. But where there is examples, and certainly within Brazil is another great example of systemic engagement, where you have a cohesive body of traditional medicine professions that have come together so that they can have a more unified voice on issues that affect TCIM more broadly. But also keeping in mind that if we don't have that coordinated voice, then you run the risk of removal of reimbursement. And we had that in Australia. A federal review failed to recognise extensive research in naturopathy and for tools of trade such as herbal medicine, and we didn't have a coordinated voice at the time. We have professions, but we have split professions, and they were all giving the government different message. Exclusionary policies where, we don't necessarily have naturopaths being included in Medicare or the Veterans Health in the United States, and also potential biases in methodology and research models as well, if there's not a clear message about what the profession is and what they do within that country. So ultimately, these pillars interact. Education creates competence. Integration strengthens the profession, regulation ensures accountability, and representation can drive integration. But ultimately, the three pillars need to be working together. So things that probably need to be done from policymakers and those from the outside to support implementation of integration. The first is establish the regulatory frameworks. Well, not necessarily the first, but it's one step. And as I said, ultimately the decision needs to be made based on the landscape of the country. What is the first step? But you definitely need professional organisation to be in place in order to inform those regulatory frameworks to make sure you have input from the profession about what goes into them. And equally, the supporting of education, the development of education courses and the accreditation. Again, input from the profession, but also enforcement through regulation. Funding research and evidence development is incredibly important as well, but also creating pathways for integration. And that's opportunities that will allow, when those education programs are put in place, with the protection of regulation, that the clinicians have an opportunity to practice in these new environments. But ultimately what it comes down to is actually unreasonable to expect TCIM professions to succeed in achieving integration without support from policymakers and institutional decision makers. Professionalisation requires a collaborative effort across all stakeholders. There's a lot of challenges around that. I'm conscious that I'm sort of going over time. But, if there's not good codification of or clear codification, and that was raised earlier for African traditional medicine, it's not always well documented and clear about who's doing what and for what reason. That can be a challenge. As I said, there's inconsistent standards between countries and variable regulatory approaches. Different countries use different models. And also the existing professional isolation can be really quite difficult. But there's lots of opportunities around that as well. There's a growing consumer demand. There is an increasing evidence base. The WHO support through the traditional medicine strategy has the potential to be really powerful, particularly in some countries more than others. And certainly there are successful integration models that are in place. And ultimately, the areas where TCIM can benefit, particularly in health prevention, health promotion, chronic disease, we have some real opportunities there that I think these health professionals are currently undervalued and underused in so many health systems. And if we can get these structures in place, then the integration that can be achieved and the benefits to community that can be achieved will be incredibly powerful. So my main take-home points is that all three pillars matter. Evidence does drive integration, but collaboration is essential. And the more that we can work globally to support these activities and support where there is strong work happening in one country for a particular profession, through the World Naturopathic Federation, we've done a really great job of supporting the countries that are trying to emerge in this way and giving them the support that they need from countries that have achieved success in some of these pillars. So thank you all very much. I just also want to quickly acknowledge the work of my colleagues in this, and particularly Jill Dunn, who is one of our PhD students, whose thesis was on professionalisation of naturopathy, and so I've borrowed from some of her work in my presentation today.
Thanks a lot, Dr. Steele. We come to our final speaker. Our final speaker is Dr. Sangamitra Patti, Dr. Pati is Additional Director General of the Indian Council of Medical Research, ICMR. A distinguished lone scholar at Harvard School of Public Health, Boston, with research experience of 25 years, she has co-authored more than 350 scientific publications in peer-reviewed journals, as well as 2 books on healthcare and several book chapters. Dr. Pati is a fellow of the National Academy of Medical Sciences, India, the Royal Society of Public Health, UK, and the Union for International Cancer Control. She has been recognized as one of India's most influential researchers. In 2021, Elsevier ranked her as the second most influential Indian researcher in general and internal medicine, being first among ICMR researchers. And in 2024, she was listed among the top 2% of global scientists in the updated Science-wide author database of standardized citation indicators published by Elsevier. And Dr. Sangamitra Patri will speak on public health pathways for integrating T&CM towards universal health coverage. It is my honor to invite Dr. Pati to the stage.
At the outset, a large thank you for all the audience present here. You are the moral booster for speakers like us, especially me, the last speaker for a pre-lunch session. So thank you. Thank you, everyone. As per the statistics, the highest risk for the speakers goes to the last speaker for pre-lunch and the first speaker for the post-lunch. So we require more moral boosters for those speakers like me. Thank you. Thank you once again. And all those who are looking at the red, yellow color in the between, it's not that I forgot to highlight. I took the inspiration from the triangle in the WH symbol. Okay. So I'll be briefly speaking on the different public health pathways for integrating traditional and complementary medicine towards universal health coverage. And I have 22 slides contrary to all my predecessors, maybe to keep you alert, because the slides will flip in minutes. Thank you. And basically, all my predecessors have been tremendously brilliant and charismatic speakers, and each one of them have deliberated on how the traditional and complementary medicine requires not only representation, but also regulation, also evidence, and at the same time, most importantly, the commonality or the common philosophy that was emphasized by each one of them is true integration. We don't require integration in pen and paper, but we require integration in the policy, in the practice, in academia, and most importantly, for the community. So I will be landscaping how India, a country to more than 1 billion population, has traditionally integrated traditional medicine into our public health system. So I come from ICMR, and I'll be just very briefly, I do not know how many of you have heard about ICMR. If anyone has done, please raise your hand so that, for the greater benefit of a larger audience, I will speak 2 slides on ICMR. So ICMR, as the name suggests, is Indian Council of Medical Research, and it is the apex body which is responsible for formulation, coordination, and promotion of both health and biomedical research in the vast country. And we do also have our evolutionary trajectory starting from 1911. For many, it may be news that it is the oldest medical research organization in the world as well. So from 1911 to present date, we have seen many changes, and currently we are the most important the think tank for the Department of Health and Family Welfare, and we do believe in the principle of integration. As we can see, we work very closely not only with the Department of Biotechnology or Science and Technology, but most importantly, the key stakeholder of today's meeting is Department of Ayush. I'll be briefly telling on what Ayush entails. And this is how we are structured. So as we can see, the Ministry of Health and Family Welfare has 2 parallel departments, Department of Health and Family Welfare and Department of Health Research, to make sure that research gets into policy formulation, program planning, and at the same time evaluation, so that there is always a concurrent dialogue and discussion between both the departments. And within the Department of Health Research, Indian Council of Medical Research is the autonomous body, and ICMR does have both its in-house research conducted by 28 institutes spanning across the country, and we do have a very strong portfolio of extramural research as well. So together, intramural and extramural research contribute to or address all the national health programs, all the national health research priorities, and also how can we be not only future ready for pandemic, but also other emerging and challenging public health threats. So now coming to today's presentation, way back when I was doing my MPH in 2000 at University of Maastricht, I came across and we had a module on medical anthropology. And that was my first, I would say, familiarity with the subject of medical anthropology and how culture, because by training I'm a physician, we never thought that physicians also need to know how culture shapes healthcare or medical care. But that was my first interaction with culture as a part of medical system. And in fact, as Arthur Kleinman had told, every country, every society's medical system is a part of their cultural system. The very fact that today we are discussing or we have harnessed the ancient wisdom for traditional and complementary medicine because it is a part of our own culture as well. So when we look at Arthur Kleinman's structure of medical sector, there the traditional medicine was housed or was kind of considered as a folk sector, but we have come a long way, and today the traditional complementary medicine as defined by World Health Organization is visualized, is perceived as a very important, or I can say critical pillar, not only in the prevention and management of chronic diseases, but also almost all the health needs of our aging population, especially because all of us are well aware about the increasing aging population. And here, traditional and complementary medicine plays a very pivotal role. So looking at the evolution journey of traditional and complementary medicine in India, already Dr. Sharma very nicely and very articulately has highlighted the Ayurveda origin, so I won't go into detail. Similarly, yoga. So as we can see, India has been the bedrock of many systems of medicine, and we do not call it traditional and complementary medicine in India. We call it traditional system of medicine. We look all the traditional medicine from a systemic perspective. And then Siddha, which is originated in South India. And again, as we can see, each system has its own focus, each system has its own principles, but at the same time, today I was discussing with Professor Holger, and we were kind of discussing what exactly is integrative medicine is. Integrative medicine is the harmonious presence of multiple systems of medicine, and each one complementing each other rather than competing. So that is what is the basic philosophy. Each one of us would agree that is what integrative medicine entails and means at the end of the day. So these are the different systems of medicine which have been evolved in India, and as we can see, we still practice each one of them, and we have consolidated them into Ayush. As the name suggests, Ayurveda, Yoga, Unani, Siddha, and Homeopathy. So each letter symbolizes each system of medicine, and we have got one ministry which works on all these systems of medicine. So as we can see, this is the evolution of traditional medicine in India and how we have integrated all the systems of medicine under a mission mode, which is known as National Ayush Mission. So these are the system of medicine, as I have already told. And now all of us are here together. How can we take forward, as Dr. Sharma very well said, knowledge of our ancient wisdom to global acceptance and convergence? And Dr. Ami has already highlighted how it can be done so, and already it has been done highlighted by our professor of pharmacology in Africa. So coming to the Ministry of Ayush, what happened is that initially Ayush was, as a department, it was working, but it was felt that Ayush requires a separate ministerial status. So 2014, Ayush became a separate ministry to give the importance, or it highlights the importance that we confer on our traditional systems of medicine. So what are the different ways we have thought of integrating, because that's the philosophy or that's the buzzword today. So how do we see different ways we can integrate Ayush into public health system? There are three ways it can be done, or it is being done in India now. First, which is very common, is co-locating. For example, if you go to a primary health center, you go to a community health center, it's not only that you get the treatment of a biomedical doctor or a clinical doctor, but you also get the support, or you can also avail the services of a T&CM as well. So they are co-located so that no one is superior, no one is inferior, both are on the same platform, and the person or the patient has the liberty to choose which system of medicine they would like to. So almost all the primary health center and community health center are equipped with that. And the second model, which is primarily peer referral. For example, a biomedicine person refers to a traditional medicine physician for some problems which he or she thinks I can't manage, and vice versa. It is not one-way referral, it is bilateral referral. And the third model, which is equally important, is parallel. Both the systems, they work in parallel, but at the same time, they share a common protocol for managing any of the chronic condition or whatever the medical problem may be. So what are the drivers and opportunity for integration of TCIM or Ayush into medical system is most importantly patients' demand, because community feels that they are more comfortable with TCIM or with Ayush medicine. So demand from patients, which is treatment which is holistic, not that one system or that one particular system they want. They want good elements from multiple systems to get a holistic, personalized care. So that is the demand from the patient has been one of the large driver. Second, the importance of Ayush in delivering preventive and promotive healthcare. The role Ayush plays in not only in health promotion, but also in prevention, for example, immunomodulators or preventing common illnesses for which we may not take medicines. And third, most importantly, in reducing out-of-pocket expenditure. That is, how can we contain cost because of the Ayush medicines are relatively affordable. So affordability in healthcare, cost containment, and reducing. At the same time, everyone doesn't have to go to a biomedicine person for the treatment. So also kind of reducing the burden of the healthcare system. So these are the three drivers and opportunities for integrating TCIM into healthcare system. So this is how we are doing, though we have a separate ministry, but Department of Health and Family Welfare very closely works with the Department of Ayush. As you can see, three departments, they work in synergy with each other. And there is, as already Dr. Ami was saying, the training of the capacity building, cross-referral. So these are the different ways which which the mainstreaming of Ayush is currently taking place in the Indian governance structure or in the Indian government system. So we have at the end, the basic level of our health service delivery as the PSCs. Now all these PSCs are renamed as Health and Wellness Center, because it's not only, it should not look like a medical, it should look like people should come to a primary health center, not only for the disease, but also for wellness. So all the PSCs are redesignated as Health and Wellness Center, and they are in the Health and Wellness Center, the Ayush is primarily mandated to provide a holistic approach and also primarily to focus on preventive and promotive health. So these are the different services that we are now providing through Ayush in the Health and Wellness Center, and yoga is present. Almost all the Health and Wellness Center have a yoga instructor, and anyone who comes with musculoskeletal symptoms or problem, they get the yoga support. Yeah. So these are the different uses, or these are the different benefits Ayush system gives to the modern health system, starting from holistic care, preventive and promotive health, symptom management, many medically unexplained symptoms, they can be managed through Ayush, then integration with modern medicine, and most importantly, your other specific practices. So this already 12,500 health and wellness centers do have these Ayush services, and there is two ways this program is being led. One is national program, which is at the central government. In the national government, all the health and wellness centers are mandated to have the Ayush services. At the same time, because in India, health is a state subject, so state also leads the implementation of this in more vigorously or more coordinatedly. So now coming to ICMR, what we are doing is that ICMR, since it is a research agency, now we have, because already the importance of evidence has been always told when it comes to Ayush medicine. And there is a very famous quote, I don't know whether you have heard or not, in the Forbes website, only in God we trust, all others, please bring evidence. So evidence is very important. That also goes for the TCIM. To generate robust evidence, Ayush Department and Indian Council of Medical Research, we have developed an integrative health research and advanced Center for Integrative Health Research. And this, what it does is that it develops different evidence-based interventions, which can be then taken up in the program. So these centers are being established in our apex medical colleges or medical schools, known as All India Institute of Medical Sciences. So basically, as you can see, it's a policy, research, and practice ecosystem where we see that the Ayush products or the Ayush clinical interventions get translated to the program. So these are the mandates, or these are the purposes of these advanced centers for integrated health research. Yeah. And also ICMR has set up a dedicated institute, which is known as ICMR National Institute of Traditional Medicine. It was established since 2006. Initially, it was a regional medical research center. Now it is converted or transformed to a dedicated research organization for traditional medicine. And 2017, this institute is completely devoted and dedicated for research around traditional medicine. And its primary aim is to generate evidence and to translate evidence around traditional medicine. And this is the pipeline, or this is the trajectory, how we translate from innovation to product. For example, someone has got any idea about an Ayush. So first is, we do have a system called MedTech Mitra. Mitra is a friend, that's why Mitra is also in my name. You might have seen. My name is Sangamitra, so Mitra means friend. So we do believe in friendship a lot. So MedTech Mitra is is a support system for the innovators to go ahead with their product and see that it sees the daylight and it gets taken up by the program. So starting with the handholding support provided to the innovators, to regulatory strategic guidance, to incubation support, as you can see, this whole pipeline to prevent the valleys of death, because these are the pitfalls where an innovator falls, an innovator is not able to take up. So we are bridging these valleys of death by giving critical support at the right time to the right person at the right place. And at the end of the day, what we do is that any intervention developed by Ayush is looked at for its cost effectiveness, that is the health technology assessment, which is the end, and clinical effectiveness, and suggested to the program to take it up. So these are the few examples done by our MedTech Mitra, and we can see those two are highlighted. These are completely Ayush product where we are looking at how the Ayush medicine can be used to address the critical challenge and very, I would say, daunting challenge of anemia among our population. And another is osteoarthritis. Currently, we have done the trial, and we are looking for its findings. So what are the challenges for integrating the traditional and complementary medicine in universal health coverage? Most important is that we still need high quality, context-specific evidence, not only on the effectiveness, but also on the adverse event or the safety and cost effectiveness. Second, we do really need standardized indicator to know whether T&CM is effective or not. Third, how do we make sure the referral pathway, record keeping, and integration in the primary care should go the way it is desired? And most importantly, training and capacity building. How do we train our integrated care physician and practitioner? And most importantly, we need more implementation research. So currently we are configuring National Health Research Policy on Integrative Medicine in India. So these are the key points or strategic points where the Integrative Medicine Health Research Policy is going to develop. It is in the draft stage. Very soon, we will see that it is in the full form and on the public domain. So India is one of the few countries which is coming up with a dedicated health research policy around integrative medicine research. So what is the way forward? Develop trials or observational studies, any kind of studies which will give us that confidence to go ahead with traditional and complementary medicine. How do we integrate our data elements that are coming from T&CM into any kind of electronic health records? Then cross-disciplinary training program. Engage communities so that they understand preferences, acceptability, and cultural relevance. And most importantly, how can we have a rapid and robust response mechanism for adverse event and misinformation? So these are the few key way forward for maybe coming WHS or coming Traditional Medicine Summit. So with this, I would like to thank each one of you, and special acknowledgement to Dr. Anurag Agarwal, who is from Ashoka University and who made this happen for my meeting for being present here, all the organization of World Health Summit, Professor Holger, who is here, and all my colleagues at ICMR. Thank you.
Thank you so much, Dr. Patti. You just heard the sound, so we're unfortunately running out of time. So we have to skip the Q&A, but almost all of the speakers will still be around. So you have 90 minutes to really deep dive into discussions and conversations. I would like to thank our fantastic panel of speakers. So we heard a lot about developments in TCIM, and we heard about important institutions, organizations supporting it. So the WHO is supporting TCIM, governments are supporting TCIM. My group is, for example, working with Cochrane. There are other supporters in the field. But we also heard about that there's still a long way to go, that there are barriers and problems that need to be solved. And we heard, it was most important, very inspiring ideas about how to proceed and how to really address those barriers that are there. I would like to thank you. There is a lot of choices here to make at the World Health Summit, and you've chosen this session. I thank you a lot for that. And if you want to hear more about TCIM, there are other options to hear more. Heber already spoke about yesterday about the World Congress on Traditional, Complementary and Integrative Medicine taking place in Rio, starting in 2 days. So perhaps there are some last-minute flights. But there also is, of course, an online option. So if you want to join in online at last minute, speak to Heber, speak to me. We can share the options with you. And of course, there is the WHO Traditional Medicine Global Summit in December, which will really be changing a lot of things, will really be groundbreaking and forwarding the field a lot. So please keep your eyes open for the summit coming up. And I conclude and thank everybody for staying here and wish you a nice lunch break.